So I'm going to talk today about leukostasis, and the reason I wanted to talk about this is because I think this condition is what a lot of us call blast crisis, and that's wrong. Blast crisis is something like more specific, so I'm going to go over some definitions. Um, it's pretty rare, but it's still possible for us to see it. I've seen like maybe one patient where there was a question of this at Kings County, and where people go after residency in their attending positions. I think it's definitely possible to see patients with this. So this right image is a patient I had at Kings County in May, a young guy coming in with GI bleed. So they sent off labs, signed out to me, and then follow-up labs, and this is what came back. So you can see the WBC count is 52, and that there's 10% immature granulocytes. So we called heme. We said, this guy has leukemia. He's in blast crisis, start chemo. And we were totally rude. The patient ended up actually having a leukemoid reaction to a severe Crohn's flare. So I wanted to kind of learn a little bit more about like how I can know how to differentiate things, and maybe it'll guide management a little bit other than call the consult and see what they can say. The image on the right is a patient who did have blast crisis from CML. So the goals of my presentation is to define what is leukemoid reaction, hyperleukocytosis, leukostasis, and blast crisis, and for us to review general management of these conditions. So first definition, leukemoid reaction, the WBC count is usually less than 50,000, and there's neutrophil predominance. This is a transient reaction that's triggered by infection most commonly, but also can be triggered by steroid use or stress. The cells in the leukemoid reaction will generally be more mature than myelocytes. So going on to this image, if you can see my mouse, these are the myelocytes and these are myeloblasts. So leukemoid reaction will have the more mature cells. And there's other like lab and micro findings that you'll see in leukemoid reaction. So alkaline will be higher in leukemoid reaction than with leukemia. And then when the lab does the smear, they'll see things like cell evacuation or Dolly bodies, which you guys don't really have to remember, but there's ways to tell on the smear. Next definition is hyperleukocytosis. So this is in leukemia, and this generally is classified by a WBC count greater than 100,000. This may be the first presentation of leukemia, like someone goes in for labs and they have a white blood cell count this high. Leukostasis is when hyperleukocytosis becomes symptomatic. So there's a high proportion of these abnormal cancer cells, and the cells, because they're less mature, they're usually like bigger, and they have low deformability, meaning they're not as like flexible. So the high proportion of abnormal cells increases your blood viscosity, and then because the cells are big and not as flexible, they can get stuck in your capillaries and microvasculature, which can cause end organ damage. The 1 week mortality of leukostasis, if left untreated, is like 20 to 40%. But if you have both pulmonary and neurologic symptoms, it's 90%. So this needs to be treated. And then finally, blast crisis is specifically in CML, and it won't really be the first presentation of CML. It'll be like CML that failed treatment. And this is defined by greater than or equal to 20% blast cells in the blood or bone marrow. So now I'm going to go more into leukostasis, because I think that's what we always think is blast crisis, and that's the emergency we need to treat, but it's called leukostasis. So for leukostasis, there's different numbers of white blood cell counts that will qualify as leukostasis for different leukemias. And the reason for that is because these different leukemias, the cells will be different sizes. If you can see the images on the right side of the screen, the top image is AML and the bottom image is ALL. And you can already see that the cells, in comparison to the RBCs, the white blood cells, are different sizes and shapes. So that's why for AML, that usually you see leukostasis at a lower WBC count than the other leukemias. So symptoms of leukostasis. So again, we talked about there's microvascular occlusion because of your hyperviscosity and because of these like larger, less deformable cells. So they'll like stick in your capillaries and they'll cause microvascular occlusion. So you'll have end organ damage from this. You can also have local decreased tissue perfusion because you have more circulating cells. You'll have increased metabolic demand of those cells, and then like the local tissues won't get like enough, like stuff to function. So you'll have local tissue hypoxemia, and when that local tissue has that, it'll also release cytokines, which like also like kind of like it's a vicious circle, and it'll precipitate end organ damage. Most commonly, like symptoms that people will present with are like neuro and palm symptoms. So headache, dyspnea, hypoxia, visual changes, dizziness, tinnitus, gait instability, confusion, somnolence. So other things to consider for these patients when they present: are they septic? They have really high WBC count. Should we be giving antibiotics to these patients? They might not be having an active infection, but they're definitely severely immunocompromised, because none of these like WBCs that are abnormal, none of them are functional because they're too immature. So your sepsis alert is going to go off. Sure, give them, like, they definitely need to be resuscitated with fluids, and it doesn't really hurt to give them antibiotics. Patients will also present with renal failure. It's another, or the kidneys are another organ that will like suffer end organ damage pretty easily. Tumor lysis syndrome. So it's important to remember for these patients with leukostasis, you can have spontaneous tumor lysis syndrome just because there's so many cells and there's such a high cell turnover. Whereas we normally think of tumor lysis syndrome like after treatment, it's the abnormal cancer cells that are, that are dying, but this is just from like the turnover of like these hundreds of thousands of cells. And then intracranial hemorrhage, I read like mixed things about this. Like some sources said like it's super rare to see this in leukostasis, and then some sources said you can see it in 10% of patients with leukostasis. So I don't think it's really established, but basically you have endothelial damage for the mechanisms I talked about previously, vessel friability, and then coagulopathy. So some people can present with brain bleeds. And then DIC can also be a presenting factor. And I'm going to go into that a little bit more in the next slide. So other lab findings we'll see for patients with leukostasis. So you can have false hypoxemia, or it'll be like falsely exaggerated, like more severe hypoxemia on your blood gas than the patient is actually having. And the reason for this is because the abnormal cancer cells will use up more oxygen so when you actually like draw the tube, there'll still be like those abnormal cells in like the blood gas tube, and it will continue to like use the oxygen for their like metabolic demand. So by the time it gets to the lab and they read the sample, it might have like a falsely low oxygen level. So the more accurate way to know your patient's oxygenation in this situation is actually the finger pulse oximetry. It'll be more accurate than the VBG. And then these patients will also have false hyperkalemia. And then the reason for this is because the WBCs are larger and they're not as flexible, they're more fragile. So they're more prone to lyse when you drop the blood in the vacutainer. And when they lyse, they'll release their cell contents. So it'll often be seen in the lab that they're really hyperkalemic, but they may not be. It'll be only hyperkalemic like in vitro, but not in vivo. And then another thing to consider is that may be the case, but a lot of these patients do have tumor lysis syndrome, and hyperkalemia is one factor in tumor lysis syndrome. But if you remember, for tumor lysis syndrome, you don't want to treat hyper-K with calcium unless there's EKG changes. And do you guys know why? So the reason for this is because for tumor lysis syndrome, you release all the intracellular contents of the cell. So you'll release potassium, and you'll also release phosphorus. And if you give calcium, it will bind the phosphorus. It'll precipitate as calcium phosphate deposits in the kidney, which will worsen your AKI or and like push you into like end-stage renal, which a lot of these patients will already have. So don't treat with calcium unless there's EKG changes. If you want to treat, give all the other stuff like insulin, bicarb, albuterol. And then finally going to treatment of leukostasis. So the mainstay of treatment is cytoreduction, reducing your number of WBC counts, and then supportive care. Supportive care, we're already pretty good at. And then one thing to note is you want to avoid packed red blood cell transfusion for as long as possible, until you can reduce the number of WBCs. That's because you're already really hyper viscous in the blood. So you don't want to, like, if you transfuse PRBCs, you're going to make the blood more hyper viscous and it will cause other problems. So leukapheresis is how we do cytoreduction. So I'm going to go over that in the next slide. The other things you can do is you can give hydroxyurea. The dose of hydroxyurea you give for leukostasis is a lot higher than our sickle cell dose. The sickle cell dose is like 15 mg per kg per day, but for leukostasis, it's way higher than that. It's 50 to 100 mg per kg per day. And its mechanism of action is that it inhibits DNA production in the cell cycle. So it'll halt the cell cycle at the G1 and S phase in mitosis, if you guys remember. And then finally, induction chemotherapy, which we'll be consulting our hem-onc colleagues for. The treatment for blast crisis is different. You want to give targeted like chemotherapy with a tyrosine kinase inhibitor, induction chemo, and then maybe a bone marrow transplant. So those patients don't really benefit from leukapheresis, I think. Oh, and then most of these patients will probably end up in the NICU. I think in other hospitals, they may be able to do all this stuff on like a tele floor, but in our healthcare system, we have these patients, they would probably go to the NICU. So leukapheresis, it's a collection, not an exchange. So if you look at the cartoon on the right, you take the blood, abnormal blood from the patient, you take out the white blood cell counts, and then you put that blood back in the patient. So what do you need? You need 2 large bore IVs, either 16 gauge or 18 gauge, or central access, because you need to be able to take out and then retransfuse those cells in. The threshold for starting is variable based on like WBC count, as we discussed previously with the different leukemias. But generally, you start when you have both neuro and pulm manifestations. And then I was trying to read if before you have the neuro and pulm manifestations, like before your mortality reaches 90%, is there any use in getting these patients this procedure before? And they said prophylactic leukapheresis doesn't really affect long-term survival that much, but like induction chemotherapy does. So that would be the thing to do if you have the abnormal lab values before the symptoms. And then lastly, I wanted to talk about the specific subtype of AML. It's called acute promyelocytic leukemia. And the reason I want to talk about this is a leukemia that doesn't have really high WBC counts in its presentation. It'll be normal or mildly elevated, usually 10,000 to 30,000 white blood cells. But this is the leukemia that you'll see like very frequently with DIC. And once you have DIC, the mortality rate is really, really high, but it's very curable. And the treatment is retinoic acid. So even if your white blood cell counts aren't like super high, this is more like what we see with like a bad infection. But if they have DIC, then think about this and think about also involving your hem-onc colleagues early so they can start the treatment. This is pretty low yield, but I think on like step 1, step 2, hourglass nucleolus was the buzzword for this, because the nucleoli look like hourglass. That's it. Do you guys have any questions?